We're now on session 5, and you guys heard that not just from Dr. Boskurt, but many others are calling for a better delineation of our initial staging, which includes, what is the onset and cause. So that's what we're going to cover here. And the first speaker is Dr. Guha, and I'm so thankful that he's able to present on primary graft dysfunction following heart transplant.
Thank you, Dr. Rami, and thank you, Dr. Carr and the organizing committee for inviting me. I'm not a surgeon, and I'm not Dr. Mark Slaughter either, so all right, we'll go ahead and get started. I have no disclosure. So during the talk, we'll talk about the definition and epidemiology of primary graft dysfunction, the pathophysiology, and the risk assessment, and some of the newer scoring systems which have come in to assess the risk of PGD prior to transplantation, and briefly go over prevention and management. So looking at the definition, there has been so many variable definitions through the history of heart transplantation. The ISHLT 2014 consensus statement defines PGD as severe ventricular dysfunction of the donor graft which fails to meet the circulatory requirements of the recipient in the immediate post-transplant period. And they also make sure that you had to exclude secondary graft dysfunction causes such as hyperacute rejection, pulmonary hypertension, and excessive intra-bleeding and other surgical complications. Now, taking all this into consideration, then the PGD incidence in a large registry data trend in the current era is about 2.5, especially when you're looking at severe PGD. But again, single center data, depending on whether you're looking at Europe or North America, can vary anywhere from 2.3 to 28%. Now, this was a recent meta-analysis published by the Stanford group, and here you can see that based on multiple studies, it seems like the severe PGD, which the definition will go into shortly, is about 7.7%. And that's really the one which really impacts mortality, both short-term and long-term. And as you can see in the lower part of this figure or the table, the severe PGD one-year mortality is almost 40%. And how do you define PGD? Again, mild PGD is all based on echo and hemodynamics, where your wedge pressure or your RA pressure, your filling pressures are high and your cardiac index is low on low dose of inotrope. And moderate PGD is when you have at least one mechanical circulatory support or more than one inotrope, where your inotrope score is greater than 10. And then severe PGD is when you have left or biventricular mechanical support, including ECMO, BiVADs, LVAD, and of course excludes balloon pump. Now, when you're looking at PGD for right ventricle, again, the hemodynamics will be essentially right-sided with a wedge pressure less than 15. So what goes into the pathophysiology of PGD? So there are both donor factors, recipient factors, and the surgery in itself. One of the things which is mainly happens to the donor is the brain death leading to LV dysfunction due to catecholamine surge, and then the transport, which involves hypothermia, leads to some contraction band necrosis in the myocytes, and then the ischemia reperfusion injury leads to some free radical injury, and they all contribute to PGD. There are certain recipient and environmental or recipient environmental factors that we'll go into in the next few slides. It's a long list of risk factors, but I'm going to go over some of the important risk factors which have been at least shown in larger studies and in peer-reviewed literature. Again, increasing donor age is a big risk factor, and the risk increases 20% for each decade increment in donor age. And it also seems like there is an interaction between the ischemic time and donor age, especially after 30 years. And cause of death, intracranial hemorrhage, like we looked in the previous slide, and size mismatch, especially after the 2014 Reed paper. Pretty much everybody uses predicted heart mass. We don't go off of either weight or height. And this study from Dr. Hall's group suggested that PHM, where there's an undersizing of greater than 30%, causes about threefold increase in PGD. And again, inotropic support in donors and donor LVH. Recipient factors, again, recipient age Preoperative mechanical circulatory support has now been shown in almost 3 studies to be an independent risk factor. And again, reduced sternotomies, and so especially in patients with congenital heart disease with previous surgeries. Now, elevated PVR was shown in multiple older studies, but with the new definition of intermax, that essentially you take those patients out. And one of the emerging PGD risk factors in the recipients is perioperative amiodarone dose. Now, there are at least 4 studies from 3 different centers suggesting that there is a dose-dependent increase in PGD with amiodarone use, and there is a recent paper suggesting that decreasing amiodarone use in these patients actually leads to decrease in PGD. Now, procedure-related factors, ischemic time greater than 240 minutes, and cardioplegia, there are a couple of studies suggesting that maybe Celsius is related to greater risk of PGD when compared to UW and HTK, and there was one study suggesting that HTK may be better even than compared to UW solution. And again, prolonged cardiopulmonary bypass times, especially greater than 120 minutes. Again, this is from that meta-analysis, again, showing the odds ratios, and as you can see, all the things that we listed, but it also tells you the actual hazard associated with each of these risk factors. And again, the certainty in these effect estimates is moderate because of various inconsistencies across these papers. This is the most cited risk score which came out of the Spanish registry, which was the radial risk score, and it contains age greater than 60, diabetes, inotrope therapy, recipient right atrial pressure greater than 10, donor age greater than 30, and ischemic time greater than 4 hours. But when you look at how well it's validated across other studies, it's so-so. If you look at least the US validation, it doesn't perform that well. This is a recent risk score. The reason I put this up here, this is from the Cedars-Sinai group, is they identified patients being on ACE, ARB, or ARNI and MRA to be independent risk factor for PGD, which is kind of new. And they again showed that amio is associated with PGD, which I think is coming out as a very common theme. And this is another risk score which just came out from UK. The reason I put this up is also because this is very reflective of current practice, because the patients here included both NRP and OCS patients, which I think none of the older studies did. So this, again, and they also go into this implant time, which I think is something that we need to pay attention to, especially in the OCS NRP era. And otherwise, everything else has been shown in other risk scoring systems as well. In terms of the biomarkers, there are multiple ones that they've looked at in both donors and recipients, but again, the true applicability in real world is really unknown at this time. But most of them are related to inflammation and extracellular matrix. Now, in terms of prevention of PGD, we all know that cold flush preservation solution, which is now essentially universal, does decrease PGD. There's one study suggesting that leukocyte depleting filters really reduces PGD to 0%. It was a little hard to believe that study, but that anything which decreases an event to 0%. But that's one single center study. And then again, continuous cold blood cardioplegia followed by controlled reperfusion of warm blood also has been shown to decrease PGD. Now, management, again, you have to exclude secondary causes in the OR, whether anastomotic or other surgical issues which could cause PGD. If that's all excluded, then you start out with inotropic support, and within a few, and a lot of the times, I think the practice is to put them back on cardiopulmonary bypass, rest the heart for about 30 to 60 minutes, and reassess. And if it's not getting better, then you go to a temporary mechanical circulatory support, depending on whether it's RV or biventricular failure, LV or RV PGD. Most often, you start out with a balloon pump, and if things are not getting better, then you go on to ECMO. Now, with ECMO, most often there is always venting associated, whether it's surgical venting through an LA vent or pulmonary vein cannula. Or sometimes even apical venting. And again, if that doesn't get better, sorry, I don't know Sorry. This is. I don't know why this.
Just you may have to conclude. It's okay. Just you may have to conclude.
Okay.
I think perhaps because you went over it, took you to the last slide.
Yeah,
I've heard
you may
that
just
they're
have to
doing that.
conclude.
around
That's
here.
all right.
No, this I actually reviewed the slides just now. This is not one of the slides at all. I'm actually surprised.
Well, I think that's a very good topic.
So I'm actually surprised that I don't know where this came from, but. All right.
We can just conclude.
Okay, we can conclude. Anyway, I'm over the time.
No, but just with you, just in conclusion. as far
We
as
have to
order-
stay on time, sir.
Yeah.
Okay.
Thank you. We have to go to
Thank you so much.
discussion.
Yeah, we are going to start discussion. Go ahead and just give us a conclusion from what you, so just as a courtesy to you, I'm sorry about that.
That was my last slide, but anyway, in conclusion, I think PGD, first of all, it needs to be recognized early, and like we were talking about, I think early identification and early early initiation of ECMO is important, and then some of the known risk factors such as the amiodarone use and ACE inhibitors, those things need to be I guess discontinued prior to.
Thank you. Thank you.
Thank you.
Dr. Guha, stay up there. We have some questions. So I just want to first introduce Dr. Menon from
Hi.
Cleveland Clinic. And we have an incredible panel. I told someone right before I started that trying to contain, is Dr. Schrisberger here? Where did he go? If it was going to be him as well, it was going to be like a goat rodeo here, because I'm in Houston, I can say that. But we're going to do a great job, I think, in trying to contain our comments and try to stay on time. How much time do we have for discussion?
55 seconds.
Wow. Can I ask the panel, I mean, we have great transplant physicians here. Any burning questions from our colleague or anyone from here regarding management or otherwise?
For
Joyce.
the risk of vasoplegia, are you taking your patients off ARNI prior to transplant while they're waiting?
We are.
You are.
But that was mostly because of our concern for dialysis post, or RRT need after transplant.
Jeff, any things of your end that we need to think about as a...
Well, it's funny because I looked at those risk factors for PGDs. The recipients, that's every one of our patients has every one of those risk factors.
You clearly haven't been to Spain yet.
So, yeah, I mean, I think you just got to kind of early recognition and early treatment. I mean, I think that the question is what's worse, turning down a heart because you're worried about PGD or the person getting sicker or not being able to be transplanted. And I think sometimes you have to make those decisions in the middle of the night based upon sort of who the patient it is and who the recipient is. But I feel like we have been having the same discussion about PGD for 10 years, and we're not any smarter than we were then.
We're smarter.
Other than maybe stopping Entresto.
That, and I think the only other difference is I see a lot of surgeons not leaving the OR as quickly. At least a lot of our surgeons are beginning to just wait and make the decision in the OR, which I know is hard because time is money for everybody, but I think that's the best thing for our patients. Dr. Menon, I'll turn it over
Good.
to
No,
you.
so let's move on in the interest of